Okay, to start this lesson, we're going to start off with just a little review of mechanical ventilation. I'm not going into tons of detail here. These are some key points that should be familiar to you, and just want to make sure we start off on the same page together. So the goals of mechanical ventilation for neonates are actually the same as they are for adults. Alveolar ventilation and carbon dioxide removal. And to do this, we usually want a tidal volume of greater than 3 milliliters per kilogram and less than 8 milliliters per kilogram. A pH we're going to want to keep between 7.25 to 7.35 with a PaCO2 of 45 to 55 millimeters of mercury. Also, same as adults, we want adequate tissue oxygenation, we want to reduce work of breathing, we want to support all spontaneous respiratory efforts, we want to avoid pulmonary tissue injury, and we want to minimize interference of positive pressure ventilation to the cardiac circulation. Our initial ventilator settings for a neonate, typically remember we want to keep low pressures while maximizing ventilation. So our PIP, we want to begin with a pressure comparable to what we used if we were bagging the baby. So if this was shortly after birth, whatever pressure we were bagging the baby with, which is typically 20 to 25, that would be our beginning pressure. And then we're going to adjust our PIP to maintain that tidal volume of 4 to 7 milliliters per kilogram. Now, depending on which reference you use, you notice on the previous slide I said 3 to 8. It depends on which reference you're using, and it depends on if you're using a lung protective strategy as to which set you're going to use. Keep in mind, if you deliver surfactant therapy, your tidal volume can change very, very quickly with the same PIP, so you're going to want to be adjusting those appropriately and as quickly as possible when you notice the tidal volume is getting larger. Our rate, we want to keep our rates reasonable, somewhere between 30 to 60. We always want to start on the lower side and then only increase as necessary. So if your patient starts off with a respiratory rate of 80, which is super high obviously, we'd start at 30, and by supporting 30 of those breaths with pressure, we should see their respiratory rate come down. PEEP, we want to start anywhere between 4 to 5 centimeters of water pressure and increase as necessary. Increasing PEEP is the same with neonates as it is for adults. We wait until we get to an FiO2 of about 60% before we start increasing our PEEP. Our I time should be somewhere between 0.25 to 0.4 seconds, although you can always use your total cycle time calculation to be more specific. And then if you're using a ventilator where you need to set a flow rate, you would set it somewhere between 5 to 8 liters per minute. Okay, this is our last slide on review before we go on. So the table here just shows you, like with your vent settings, how your inspiratory time, inspiratory flow, and change in pressure are going to affect your overall patient outcomes. So if you have a longer I time, it's going to allow for more gas exchange, which will increase your tidal volume, and it will improve your oxygenation. Inspiratory flow, a higher inspiratory flow is going to deliver more volume without changing the I time. Typically, if we're going to increase flow, it's usually for patient comfort. So they're getting that breath faster. They're not sucking so hard. Change in pressure, you know the higher PIP can increase the amount of gas delivered, and PEEP, optimal PEEP will stabilize the alveoli and improve gas delivery with each inspiration. And remember, the difference between your PIP and PEEP will determine your tidal volume. So if you do not change your PIP, but you go up on your PEEP, you're actually creating a smaller tidal volume. So, pulmonary factors in regards to the patient itself, lung compliance. You all know low compliance prevents adequate stretching of the alveoli, so your tidal volume will be lower, and airway resistance restricts gas flow to the alveoli, which can decrease your tidal volume if you don't change your pressures. So before you go any further, you're going to want to make sure that you know what happens to your tidal volume when in pressure ventilation, when your patient's resistance increases or decreases, your compliance increases or decreases, or if your inspiratory time increases.